Okay, guys, I think I'm going to start. Okay, so good evening, everyone, and welcome to the fourth LEJENDO, which is the Lister Endometriosis Journal Club. We are super happy to announce that we're doing it with the partnership with European Endometriosis League. And of course, many thanks to Carl Stotz for supporting us with LEJENDO. I'm sure there will be some newcomers today, and I'll briefly explain how LEJENDO works. It's essentially a journal club with a bit of a twist, where we meet once a month on the 6th of every month at 6 p.m. UK time, and our team will briefly go through 6 presentations or 6 papers, 6 articles, and of course we will have 2 invited speakers talking about their work and their presentations. Quickly to introduce the team, my name is Mikey Adamczyk, and I'm a consultant gynecologist and endometriosis surgeon working with the CMIC London team and in the NHS. We, of course, have Shaheen Kavali, who is at the moment in Canada, holidaying. He's with us listening. I'm sure he will chip in when needed. So Shaheen, I hope you're having a lovely holiday with your family. Ben Mondelli is our senior fellow, waving to us over there. We've got Avril Bahi, who is a current CMIC London fellow, and Kai Fleischer, who is the future CMIC London fellow. So there's a lot of fellows going on around. Pavlo Dimitrievich works with us on the NHS side, but he's soon, hopefully soon, will do his fellowship soon. Of course, I want to thank our invited speakers for joining us today. So thank you guys. Martin Harsh, who is a consultant gynecologist at the Oxford University Hospital Endometriosis Center, and Martin will speak about his publication on ultrasound prediction of segmental bowel resection in women with rectovaginal endometriosis, a single center experience. Now we've got another quite an interesting presentation and publication for later on today, because the publication is going to be presented by Professor Oleg Tarantula, who is a professor of pharmaceutics at the University of Oregon State University. And Professor Tarantula will speak about targeted nanoparticles with high heating efficiency for the treatment of endometriosis with systematically delivered magnetic hypothermia. So this is quite an interesting paper, and I'm really looking forward to it. So thank you both for joining us tonight. Lastly, the Journal Club was originally designed for physicians, but I'm super happy and I'm really excited that we have more and more patients advocates joining us today. So for that, I would like to thank you. We will try our best to keep the medical jargon to the minimum, but please excuse us if that's something, it's sometimes quite hard to do. So apologies in advance if we use a lot of medical terms. We will start with Avril, that will take us through, Avril and Pavlo, that will take us through 3 of the publications that we've picked up for you for this week. And then we will move to Martin's presentation. We will have then another 3 small presentation, and then Prof. Tarantula at the end. So please submit any questions that you have to the Q&A. This is really a relaxed journal club, so we want to have a lot of interaction with you. So please ask as many questions as you can. So Avril, what do you have for us this month?
Hi guys. Okay, so at the moment, today, let me just release our first poll first that's related to this paper. So what I have today for us is a paper produced by Professor Roman and his team, recently published in JMIC in February this year, looking at whether stoma could prevent the risk of rectovaginal fistula in patients who are at high risk. And this is, we know, women who have large rectovaginal nodules who've had both vagina opened and bowel opened as well. So for this study, they included patients with enzyme criteria A3 and C3, that means deep infiltrating endometriosis in both the rectum and the vagina. And these patients have had vaginal excisions with or without hysterectomy, followed by a posterior vaginal suture and removal of rectal nodule, either by discoid excision or colorectal resection. And what was interesting about this study is this occurred between 2 time periods. So the study period was between September 2018 to June 2022. And between September 2018 to March 2020, the author and his team used what they call a restrictive use of stoma. So they use stoma in patients with large nodules, low nodules, and they took into factor like obesity, tension on the staple line, and unsatisfactory bubble tests. And then from April 2020 onwards, they adopted a policy of not performing preventative stoma, even in patients with large nodules, except in rare cases where if they found that the surgery was very long, there was a lot of ooziness or hemorrhagic points in the surgery, or if the rectal suture was notably low, or if they weren't happy with their fluorescein test looking at the vascularity of the bowel edges. And they also had quite a very robust follow-up. So most of the patients went home on day 2, day 3, and following that, a specialist nurse visited these patients daily from day 4 to day 9. And for any patients with a temperature of more than 38.2, or if their blood test showed that their CRP or white cells were rising, they would ask the patients to go back to present to the hospital, get assessed by the surgeon, have a CT, and then have a laparoscopy where they would do a rectal bubble test. And if there was apart from the patients who had a temperature due to a UTI, and if there was a fistula, then they would treat it with a stoma. So this table is a bit busy, but I'll just take you through it. This is the baseline characteristics. So in total, they had 168 patients, 87 in the first period, 81 in the second period. So the baseline characteristics were almost comparable, apart from in the first period, most higher proportion were smoking, had past ART management, and more severe dysmenorrhea and deep dyspareunia. Whereas in the second period, these patients had higher proportion reported bladder dysfunction, sciatic pain, and digestive tract occlusion symptoms. Intraoperatively, so there was a 4-fold decrease in the use of stoma in the second period. So 32.2% in the first period, 8.6% in the second period. And in terms of endometriosis lesions, they were almost similar between the first and second period. What was interesting was that even though the study period was only 35 months, there was a lot of change in the surgical practice in the second period. For example, the nose technique. It was not done in the first period, but 10 was done in the second period. They also used fluorescein to look at the vascularity of the bowel edges. They also used mesh to interposition it between the vagina and the rectal sutures. Again, 0 in the first period, and 22% and 7.4% in the second period. And the authors did acknowledge that this was a limitation, but did do some statistical analysis and found that this did not affect the rate of fistula. So in terms of results, so complications, there was no significant difference in any of the early postoperative complications, especially rectovaginal fistula, despite having a 4-fold less decrease in the use of preventative stoma. They also looked at the relationship between stoma and rectovaginal fistula. And interestingly, in the second period, despite having such strict criteria on who should have a stoma, one patient who had a stoma did develop a rectovaginal fistula. This is her characteristics at the bottom here. Her height of rectal suture was about 4 centimeters, and she also had bilateral parametrectomy and some bladder dysfunction. They also identified that smoking did increase the risk of rectovaginal fistula by 3-fold as well. And so the authors did emphasize on counseling smoking cessation programs preoperatively to reduce the risk of fistula. But the main gist of this study was that preventative stoma did not significantly decrease the rate of rectovaginal fistulas in women with concomitant opening of the vagina and the bowel. Yep, that's from me.
Really, really nice, Avril. Thank you. Another good publication from Professor Rahman and his group. Actually, Martin, what are you guys doing in terms of stomas and preventative stomas? Is that something that you guys, what is your opinion on it? What's your view on it? You muted.
Really good question, Mikey. I think it's an individualized situation depending on the disease and the proximity of the nodule from the anus, and so the lower it is, and perhaps the higher the likelihood of a fistula, the more the likelihood of offering a stoma. I agree. I don't think a stoma necessarily prevents the rectovaginal fistula, but may help manage the patient's symptoms should they develop a rectovaginal fistula. So someone that is higher risk of developing one, more likely to offer an ileostomy. And yourself?
Interesting. I have to be honest, I can't actually recall a single patient since I've been in training as a consultant that we've done a preventative stoma. Most of those patients are healthy and they do very well. I guess for the ultra low resections, I can see there's a place for it, but that's not something that I've observed, at least in our practice, daily practice. But as you said, it's a very individual approach that needs to be obviously discussed with a patient. Okay, thanks, Avro. Pablo, what do you have for us?
Yep.
So I've got the pleasure of talking about a rather contentious issue that I think we can all agree on for a paper about laparoscopic entry techniques and which would you prefer. It's been published in the International Journal of Gynecology and Obstetrics, and it's a literature review that basically goes from the inception of databases through February 2021 and looks at all randomized controlled trials comparing different laparoscopic entry techniques that were used across these 6 databases. 25 randomized controlled trials were identified, encompassing 6,950 patients. And the aim of the review was to update the evidence about the safety of the main different entries and basically to try and find an answer to the debate that we've been having for the last 2 decades about which one is the best and what should we be using. So entry-related complications and total time for entry were compared between the Veress needle, Hasson entry, direct trocar, and calculated pool odds ratios and mean differences were used. Overall, they found that the Veress needle was had significantly increased odds ratios for omental injury, failed entry, and extraperitoneal insufflation when compared both to direct trocar entry and Hasson open entry. The direct trocar was found to have a lower visceral injury and lower trocar site infection rate compared to open. And so overall, the study recommended that the direct trocar method may be preferred over Veress and open as an entry technique due to the lower risk of complications. So in terms of the literature, for the next slides, if we move on, there were 13 randomized controlled trials compared the Veress needle to direct trocar, 11 that compared Veress needle to open, and 6 between direct trocar and open methods. The risk of complications were compared amongst different entry methods using a Pareto odds ratio, as events were expected to be rare, and a p-value of less than 0.05 was considered statistically significant. Furthermore, the mean difference in total time for entry among the different entry methods was also calculated. So on this slide, we've got a forest plot analysis looking at both individual and pooled Pareto odds ratios with 95% confidence intervals. The one on the left looks at a mental injury when using a Veress needle compared to a direct trocar, which does show a preference for direct trocar. And also the one on the right looks when comparing Veress needle to open entry. This is in keeping with previous findings, and one of the ways they suggest that this might be the case is that with a Veress needle entry, it's removed before primary trocar insertion, and because of that, a mental injury can sometimes remain undetected for a prolonged period of time. On the next slide, we've got 2 further forest plots, and they look at the one on the left looks at the rate of failed entry when using a Veress needle compared to direct trocar, and extraperitoneal insufflation when compared to open on the right. The paper suggests that the increased risk of failed entry seems to indicate that potentially Veress needle might be a more difficult technique to learn and difficult to be correctly completed. And they argue that the direct access with trocar might have a more positive impact on complication rates, even with less experienced surgeons. The study, very interestingly, did not actually find any statistically significant differences in odds ratios when we compared direct versus open in terms of vascular and mental injuries, failed entries, extraperitoneal insufflation, or trocar site bleeding, but it did find an odds ratio of 0.17 for visceral injury and 0.27 for trocar site infection. It did also have a significantly lower total time for entry compared to the open method, with a mean difference of less than 135 seconds. And they attribute this risk of injury due to the requirements of sharp surgical tools for open entry when compared to direct trocar, and the reasoning for the surgical infection, which I'm not sure is if I really necessarily agree to it, but they say that it's primarily because of the increased length of time for that procedure and also the need to handle more surgical tools. In this paper, very rightly, I think they do acknowledge quite a few limitations. And the main three are basically that they're not able to stratify analysis, firstly on operative variables. So such things such as the diameter of the trocars, the angle or site of insertion of the Verus needle or trocar, what type of trocar was used, whether it's blunt or sharp, patient positioning, the amount of elevation between the abdominal wall and the surgeon's hands, or even the type of incision in the fascia. Second of all, they are unable to substratify what the characteristics of patients were in terms of extremes, whether these risks were associated with patients who had higher BMIs or lower BMIs. And they rightly acknowledge that further research needs to be done into this in order to perform a more tailored approach to these patients with extreme ends of BMI. And finally, they point out that a surgeon's experience was not able to be analysed, and in fact, the volume and expertise of surgeons could definitely impact the outcomes and methods for laparoscopic entry. So that's that one.
Well, thanks, Pablo. It's an interesting publication from Diego and the team. I often get asked by trainees, I'm sure Martin, you are the same, and Shaheen and everyone else on the call, what is the best abdominal entry? And my answer is always the same, that you should really know how to have at least 2 or 3 different types of abdominal entry, because you never know which one you might have to use. We are in the school from Shaheen, where all of us do open Hassan's entry, but it's it's always a good idea to know how to use a Verus needle, because you might eventually start docking a robot where you're going to be using a Verus needle, or you might be doing a Palmer's entry or Jane's entry, where knowing how to use a Verus needle or do a direct trocar entry is quite important. So I think for anyone listening that is still in training, certainly try all of them, because you should have more than one in your armory. But yeah, thank you very much, Pavla. Avril, I think you've got one more.
Yes, so one more before Martin's paper. So my paper is about endometrioma and risk of severe PID. We know that PID is more prevalent in patients with endometriosis. We know that endometriosis is a risk factor of requiring surgical drainage for PID. But what this team from Israel wanted to look at was whether the presence of endometrioma did affect the severity of PID or not. So what they did was, so this was a retrospective cohort study. What they did was they looked at all the notes of all the patients who was hospitalized for PID, and they had quite a strict criteria for defining PID, because the symptoms of PID could be similar to the symptoms of endometriosis. So they defined PID with symptoms of acute pelvic pain, cervical motion, or uterine tenderness with one of the following: raised temperature, raised white cells, or raised CRP. And then, because this hospital was also an endometriosis unit, they looked at the electronic records and cross-reference it with patients who had endometriosis. And they included patients with, number 1, proven histology in patients who underwent previous surgery. They included patients who had radiological evidence based on ultrasound or MRI. And interestingly, they also included patients with who they suspected have superficial endometriosis. And the way they included these patients was, number 1, they needed to have very prominent severe symptoms, and number 2, convincing examination findings as well. So uterosacral ligament tenderness, nodularity, or uterine motion tenderness as well on examination. And what they had was 116 patients, 57 in the control group, 59 with endometriomas. Again, their baseline characteristics were almost similar, apart from patients in the endometrioma group was higher and was older, and patients in the non-endometrioma group had a higher proportion of IUD present. They also looked at predisposing risk factors for pelvic inflammatory disease. So if they had any kind of intervention that could increase their risk of having a PID, and only patients with endometrioma, the only significant difference was more patients had oocyte retrieval. And the authors mentioned this probably supported the fact that patients with endometrioma had a higher risk of infertility. And so interestingly, yes, the patients with endometrioma had a higher risk of having severe PID requiring CT-guided drainage or surgery or tubo-ovarian abscess. So if you see here, about 1/3, more than a third of patients, well, about 1/3 of patients with endometrioma who had PID then went on to have drainage or surgery, and more than half of them also developed tubo-ovarian abscess. So what does this and they did also logistic regression analysis, and the odds ratio of having severe PID with the presence of endometrioma is 4.36, which was quite significant. So what the authors concluded for this study was, number one, have a higher threshold for treating patients with endometrioma with symptoms of PID. And number two, also have a higher threshold for taking them to theater for surgical drainage, knowing that they are at risk of having severe PID and at risk of having tubo-ovarian abscess. And that's me.
That's a really good, interesting presentation, Avril. I personally found that operating on patients with tubo-ovarian abscesses with non-endometriosis is one of the hardest things I've ever done in my life, I think. We recently had a patient actually where we work that had non-endometriosis and quite a large tubo-ovarian abscess. And I must say, it's not an easy operation. Definitely take a friend with you if you're doing it. Avril, did they mention what's the pathophysiology of why does it happen that patients with endometriomas have increased risk of PID? Is it because the texture of endometrioma, the contents of it, is a good medium for growth?
Yeah, so they mentioned about the contents of the endometrioma being a good medium for bacterial growth, but that was just a hypothesis that they had.
Okay, well, it's interesting. Okay,
yeah.
Martin, over to you.
Thank you, Mikey and team. I'm just trying to share screen, but I need to be host enabled.
We'll do it in a sec.
Thank you.
Okay, I think you can go.
There we go. Okay, can everyone see my presentation?
Yep.
So I guess I'd initially like to start by thanking Mikey, Avril, Pablo, Kyle, and importantly Shaheen for setting up LEJENDO and inviting me to present this topic. The sun's suddenly come out and is blinding me. But this is a paper that myself and our team, combined Oxford, now that I'm in Oxford, and UCL team, that we're thinking about calling UCLOCS to rival the LEJENDO. I published recently in JMIG, looking at the prediction or the ability to predict whether someone will need a segmental bowel resection based on various parameters, preoperative parameters. And it's a single center experience, which we'll discuss in the limitations shortly. So bowel endometriosis, firstly. Image on the left nicely shows what a normal bowel looks like histologically, and then the image on your right shows the invasive properties of endometriosis when it does involve the bowel. The serosa is involved, the subserosa, the muscularis, and commonly the submucosa. On rare circumstances is the mucosa involved, but it's a challenging disease to manage, as I'm sure everyone on the panel and watching can agree. The surgical strategy is principally divided into three approaches: either a segmental resection, chopping a lump out; a disc resection, where you kind of in circular approach to removing the disease that's there, or shave and try to shave the disease off the bowel, ideally without opening the bowel. And this is important. The decision for the technique is really important for two principal reasons. One is trying to prevent disease persistence and two, preventing the complications that can ensue from the different techniques. So, in this study that was published recently, that the likelihood of persistent or recurrent disease with segmental resection was significantly lower than shaving. So for those people with bowel disease, that the thought is that segmental resection may be more commonly able to get the disease out than a shave, which is where a more personalized or individualized approach to surgery is required to ensure that you're doing the right procedure for the right patient. But it's not just about getting the disease out, it's about balancing that with the potential risks that are associated with the different surgical procedures. Rectal shaving is associated with less post-operative voiding compared to segmental resection or discoid excision. The difference between the discoid and segmental resection is not thought to be significant. So it is that opening of the bowel lumen that's thought to increase the risk. Then moving on to thinking about the other additional risks at the time of colorectal surgery. Complication rates increase dramatically when you open the bowel lumen, 2 to 2.2% with a shave, increasing to around 9% when the lumen's opened. And the risk of rectovaginal fistula with disc and segmental resection being comparable. In the study again by Professor Roman, fantastic amount of data that's being published there that seems to infer that it's the opening of the bowel, the disc excision or the segmental resection that's going to be increasing someone's risks of fistulation. So adopting the appropriate surgical technique for the appropriate disease is really essential, and knowing how to predict what that appropriate surgical technique is really important. Historically, perhaps didn't have as accurate imaging or as detailed or preoperative clarity as to what factors are likely to determine the approach we take. And some people may have been accused of being a bit too radical, and some people may have been accused of being a bit too conservative with their approach. But it's mostly essential for patients, and any patients watching, the information that I think I want to give across and that you as a patient may want to receive is, what are your risks going to be at the time of surgery, whether that's post-operative complications, or what are the risks going to be of leaving disease behind on the bowel if we attempt to shave for a large nodule of endometriosis that's unfortunately going to struggle to get out if it is a really large nodule. MDT planning is crucial, and having the knowledge to discern which appropriate technique is required and what modalities you're going to use to determine the surgical procedure is really key, and we'll come on to that with this. So the study question is, which preoperative data are associated with bowel resection? So we used a single center experience at UCLH, which is one of the largest BSG endometriosis centers, one of the first. The data that was included was from 2013 to 2019 from 3 consultant surgeons. And our data sources were the BSG database and ultrasound reports from a single diagnostic ultrasound center that's been in place under the same leadership of Professor Yurkovich from the origin of this study. So we identified about 320 patients with bowel disease. We excluded those that had no bowel surgery or imaging wasn't available, and included 228 patients. Of those, around 90% had a shave, 2% had a disc, and nearly 9% had a segmental resection. Demographics, median age was approaching 40, BMI was around 25, dysmenorrhea scores around 9. There were 5 cases of hydronephrosis, and adenomyosis was present in 50% of cases. So looking at complications, I think it's important to declare both benefits from surgery as well as harms that are associated with surgery. And in 3 cases of rectal shaves, there's bowel injury, a bladder injury, as well as ileostomies performed with increasing frequency depending on the radicality of the surgical procedure. So looking at the symptom scores, so the pain score is on the bottom, and then the number of responses aligned to that. And the symptoms that we chose from the BSG database to analyze, principally dysmenorrhea, dyspareunia, cyclical dysgeusia, and non-cyclical dysgeusia. So thinking about symptoms and whether there are any particular symptoms that are associated with bowel resection, cyclical dysgeusia. Now I'm going to move the icon of of our beautiful faces to the other side so I can try and see. But the cyclical dyschezia was predictive of bowel resection with an increased Oz ratio of 1.53 with increasing each unit of cyclical dyschezia. So that's about 50% increased risk of bowel resection with increasing point of cyclical dyschezia. So that's pain doing a poo at the time of your period for anyone that's watching. This is a patient. Sorry. Oh, did I jump ahead? So thinking about those, the likelihood or the percentage of those patients that underwent a bowel resection depending on their cyclical dyschezia score. So those that had a cyclical dyschezia score of 10, there was around a 60% likelihood of them having a bowel resection. And the majority of those with a high cyclical dyschezia score had a bowel resection compared to a smaller number with lower cyclical dyschezia scores. So it appears as though cyclical dyschezia is associated with the risk of requiring a bowel resection. And we'll discuss that in comparison to previous literature in a bit. So think about ultrasound features. We exclusively used ultrasound, as UCLH has a long history of using ultrasound with some of the forefathers in this case of ultrasound, Professor Yurkovich. So we assessed the number of nodules present and found that greater than one nodule of endometriosis in the rectovaginal space was increasing, or in rectosigmoid nodules was increased your likelihood of requiring a bowel resection. Bizarrely, the presence of nodules in the vesicouterine pouch was also associated with a segmental resection. We can come on to talk about this later. And then increasing number of nodules in the rectovaginal septum or rectovaginal space 2 and above were again associated with the requirement for a bowel resection. So in univariate analysis, both the nodule size and the total number of nodules were associated with the increased likelihood of having a segmental bowel resection. And if we think about the nodule number and then the percentage of patients requiring a bowel resection, those with greater than 5 nodules detected on ultrasound would have around a 50% likelihood of having a bowel resection in our retrospective cohort. And this appeared to increase gradually with increasing number of nodules. So then looking at a multivariate analysis to see which factors are independently associated with bowel resection. So the original analysis I've just described are looking at that individual predictor and the outcome being bowel resection, whereas these subsequent analyses look at the individual factor and control for all other factors. So when controlling for all other factors, the number of nodules in the rectovaginal septum was associated, and the size of the nodule was associated, as was cyclical dyschezia. Vesicouterine pouch was presence of deep nodules in the vesicouterine pouch was of borderline significance. When comparing this to previous studies, both ultrasound and MRI has been used to assess whether they can predict the likelihood of bowel resection with limited number of studies. And this study on the left looking at MRI found used a cutoff of around 11 millimeters, was able to predict the likelihood of bowel resection or requirement for bowel resection to remove the entire disease, and that's 11 millimeters in depth. What's important to note in our analysis, we used the largest size recorded, as we were not able to decipher from the data which parameter was length, width, or depth. Again, a limitation of our study. So comparison with other studies, looking at preoperative indications to determine the technique, and I'm sure lots of people have seen this paper published by Malzoni that is, I think, fantastic. And it identifies bowel nodule features that can help predict, through ultrasound, that can help predict the requirement for different surgical procedures. So in the study, they measured the length, the circumference around the bowel that it occupied, as well as the maximum infiltration depth into the bowel, and they found that of those nodules less than 3 centimeters, the majority were able to be achieved, or all were able to be achieved through nodulectomy or a rectal shave, as we describe it here. But with increasing size, there's an increasing requirement for segmental resection. And this is according to their length. Having a look at the number of bowel nodules with increasing number, similar to what we found, there's an increasing likelihood of requirement for segmental resection, as well as the diameter. I think most importantly, I'm not sure whether I covered this in my, oh, there we go. The depth of invasion into the bowel, which is reported here, it is one of, well, personally and with this data, an essential finding for someone's ability to be able to excise the disease from the bowel without opening the lumen. And I think the crude cutoff, or the statistical cutoff that was used here, is a depth of greater than 7 millimeters into the bowel. It is used to help determine the approach used. So nodule length of greater than 3 centimeters and greater than 7 millimeters in depth, they adopt a segmental approach, but less than 7 millimeters, they consider shaving. So nodules between 2 or 3 centimeters, but greater than 7 millimeters, then a discoid may be appropriate, and a small nodule of less than 2 centimeters in length, but less than 7 millimeters you can shave, and greater than 7 millimeters, again considering a disc. So that depth of invasion of over 7 millimeters is the likely predictive factor in the study to ascertain whether or not someone's going to need luminal opening of their bowel. And that again helps theatre planning, helps know who's going to need to be at the time of surgery, how long the procedure is going to take, and counselling for the patient. Make sure I'm not running over too much. So again, comparing cyclical pain symptoms and the cycle-related dysesthesia increases somewhat probability of rectal endometriosis. So the key symptom that I tend to ask in clinic is this, whether they've had cycle-related dysesthesia, to ascertain whether or not they should go for an advanced ultrasound or a detailed MRI scan. Clinical sonographic follow-up of patients after those with significant dysesthesia had a significant greater length of bowel lesions. So not only was it associated with the presence of disease, but increasing cyclical dysesthesia is associated with increasing size of the disease. So conclusion from this study, the size of the largest nodule and with multiple numbers of nodules in the rectovaginal septum increases the likelihood of requiring a bowel resection. Cyclical dysesthesia is independently associated with bowel resection, and these support accurate preoperative counselling, theatre scheduling, planning, MDT requirements, and hopefully enhances patient safety and patient counselling. So strengths, multivariate analysis, expert ultrasound in a single centre using limited number of surgeons and limited number of ultrasound practitioners. But again, that's also a limitation if there's only a single centre experience. We only use those patients that had bowel surgery, and further work is required to further analyse the parameters that we've discussed it in other centres, and we're certainly keen for any collaborations. Thank you very much.
Brilliant, thank you, Martin. Cheers for that. That was a really good presentation. Just to emphasize, if there's any questions, please ask them in the Q&A. Please don't be shy and ask as many questions as you want. I guess I have a question for you, Martin. In your sort of set in Oxford, what is the modality that you guys use the most? Does everyone routinely gets a detailed ultrasound scan when you're querying if there's been a rectal disease, or do you split them by half and half have MRI, half have scan? What do you do?
Thanks, Mikey. In Oxford, it's slightly different to the provision that we have at UCLH, and we do veer more towards MRI. I think the benefits of MRI is its ability to be standardized in terms of the images and views that you can present at the time of an MDT as well. The ability to have those images that you're able to present in front of a group and share with people perhaps not even in the room. So we do use a bit more MRI than ultrasound here in Oxford, but we still have advanced ultrasound clinics as well. What about you?
We do rely a lot on MRI. So certainly, if I think that I have a patient with rectal disease, I most certainly will do an MRI scan. And with time, I've realized that the more you look at MRIs, kind of also you seem to pick up the disease by yourself, just looking at the images constantly. But whenever there's any query about rectovaginal involvement or rectal disease, all the patients go through our MDT. We all look at the images together. So,
do you have any set cutoffs in your unit as to what you use to predict whether someone's going to need a shave, a disc, or a segment?
So we've got a very standardized approach in terms of size of the disease. We rely a lot on our colorectal colleagues to chip in. We tailor the operation pretty much for the patient, as you know, as what they want. Good example was I had to have a chat with one of the patients only last week. A lady that had quite a large rectovaginal nodule going into the sacral nerve, which has been waiting for quite some time for operation. But when we spoke to her in clinic, she was one of those people that really didn't want to have any complications. So we had to have a good chat of what exactly we're going to do, how aggressive are we going to be. So that's the MDT sort of approach that we have. Okay, I guess we can take the rest of the questions at the end. And I'm aware of the time. I think we will skip one presentation from our team. Okay, so Avril, maybe if you go quickly with, or Pablo, with your fertility presentation. Okay, and
Martin, do you mind giving the host back to me? Sorry.
Because we do have a really interesting paper from Oleg, and I've got a lot of questions, so we do want to hear all about it.
All right. So quick one. So Pablo's going to start on this round. So go ahead, Pablo.
Yep, so I'll keep it very short and sweet. So the paper is the impact of surgery on fertility amongst patients with deep infiltrating endometriosis. It was published in February this year by our Danish colleagues. And the rationale for conducting this study was to investigate the pregnancy and live birth rate, as well as the time of pregnancy after surgical resection of DIE, deep infiltrating endometriosis, and also the if complications from these surgeries would have an impact on these rates. It's a retrospective study over 10 years in the Aarhus University Hospital in Denmark, which is one of the 2 referral centers for DIE. And all the women underwent either segmental or disc resection with no shaves performed. Exclusion criteria were if the patient unfortunately had a miscarriage prior to 12 weeks, an age cutoff of over 41 years, which is the upper age limit for funding through the Danish Health Services fertility treatments, or if they had no intention of subsequent pregnancy. The crux of the study is that they found that there was that the post-operative pregnancy and live birth rates were in keeping with patients who had undergone conservative management. But very interestingly, the complication rate was about 19.7%, 16.6% of which had a grade 3 complication. But for these patients, they had live birth rates of about 50%, which showed that there was no difference for patients who had the complications compared to patients who had not had complications. On the next slide, we can see the study population size and the samples that they had, as well as the characteristics of the study population. The guidelines for the units were that they required a preoperative BMI of 30 or lower to decrease risk. However, 14 patients with a BMI of over 30 did have the surgery. Other causes of infertility were noted as being civil status, polycystic ovaries, uterus didelphys, and previous bilateral salpingo-oophorectomy in one of the patients. MRI was the primary imaging modality for infiltrating endometriosis diagnosis and surgical planning, and only 5 patients did not have an MRI prior to their surgery. So on the next slide, we have a look at the postoperative fertility and pregnancy characteristics. They had a live birth pregnancy rate of 53.9%, and the majority, 61.5%, obtained pregnancy after ART. So ART is any assisted reproductive techniques that are used for any of the patients listening, so whether that's an insemination or IVF. Specific information on the number of patients who intended spontaneous conception postoperatively prior to ART is available, but 126 patients were treated with ART, 67.5% got pregnant. The pregnancy rate for women with MR verified adenomyosis was 64.3%, and women with primary infertility preoperatively had a post-op pregnancy rate of 64.9%. With 34% of them being spontaneous pregnancies. And patients with secondary infertility prior to surgery had a post-operative pregnancy rate of 46.7%, and 28.6% of these were spontaneous. The median length of time for spontaneous pregnancy was 9.8 months, whereas women who underwent ART techniques, the length of time was increased to 12.6 months. On the next slide, we see the rate of complications that the study had. At 19%, their risk of complications was higher than they expected, but the authors contribute this due to the length of the study over 10 years and how this has been a learning process for them as well in terms of improving or updating their techniques. On the next slide, we talk about how the patients who had 1 or 2 postoperative complications, 16 patients had this, but 50% became pregnant, 7 by spontaneous conception and 9 by ART. The median length of time to pregnancy was 10.7 months, but complications did not statistically significantly affect the pregnancy or live birth rates. So where does this study fit into the current body of evidence? I mean, there is still an ongoing debate as to whether excision surgery affects fertility or worse outcomes for ART. And that's one of our poll questions for whether or not you would include a fertility input for these patients. But we know that when we compare this study to other data, spontaneous pregnancy rates with expectant management is found to be at 21 to 36%. And 39.7% after ART. So whilst it is on the lower end, it does show that pregnancy and live birth rates are in keeping with conservative management, even if they've had surgery. So it implies that patients who suffer with bowel endometriosis and significant dysphagia should not stay away from surgery because of the fear of complications affecting the chance of their pregnancy.
Great, thanks, Pablo. Avril, I think we can quickly go with your presentation, if you're going to keep it nice and quick. If not, I think we should move towards the second speaker. What do you guys think?
I think we should go for the second speaker, Mikey, because it's already almost 7 and this is a really interesting paper.
I know, I'm also looking forward to it. I know Martin has to dash and do his clinic at 7 o'clock. So Martin, thank you very much for having us.
No. Thank you for inviting me, Mikey. And I'd love to join you again.
And see you in Manchester.
Yeah,
Oleg, we've been really looking forward towards your paper. I know when Ben first saw it, he was very excited, and he was like, "Mikey, you have to read this. It's very interesting. It's definitely a different perspective." It certainly is. I think there's a lot of potential from your presentation. I certainly have a lot of questions about it. Later on, I'm sure we will have some questions from the audience. So over to you, Oleg.
All right. First of all, thank you so much for inviting me here, to join your journal club. And, despite the fact that I'm not an expert in endometriosis, but, I would like to share our perspective from the nanomedicine point of view. So first of all, before I start, I have to acknowledge, because I mentioned that I am not an expert in endometriosis, I ran this project together with Dr. Ovi Sladen, who is the professor here at the Oregon Health and Science University, one of the main medical schools here in Oregon. since I'm not the expert on the team in endometriosis, actually I specialize in nanomedicine and specifically in the development of different nanomaterials. And for many years, I used those nanomaterials for imaging and treatment of cancer. And I'll just give you a brief introduction of how we end up with this endometriosis project. So nanoparticles, they have a huge potential in cancer because they can deliver, preferentially drugs and imaging agents to the cancer tumor. And one of the reasons for that, because cancer tumors, they are highly vascularized, and also they have immature blood vessels. So meaning those blood vessels, they have the small opening like fenestration, like nanometer size. And it causes the leakiness of those blood vessels. So what happens if you inject nanoparticles systemically, and when they reach cancer tissue, those nanoparticles, as you can see here on this slide, they can escape, extravasate from those fenestration and accumulate in the cancer tumor. So this is something what we call a passive targeting, which allows us, to deliver a significant amount of nanoparticles to the cancer tissue. We also have something what we call active targeting, because cancer cells, they overexpress many receptors. And what you can do, if you know the receptors, you can find the ligand for that receptor and attach that ligand to the nanoparticles. So when nanoparticles, they accumulate passively in the cancer tumor, after that, by using that ligand, they can interact with the cancer cells and specifically internalized by those cancer cells. So several years ago, when I met Dr. Sladen, we started to discuss the potential to use nanomedicine for endometriosis. And at that time, we reviewed some literature, and we saw that endometriosis is also angiogenesis-dependent diseases. And the literature also suggested that, the blood vessels in endometriosis lesions, they're also characterized by that leakiness. And we started to work on that. So Dr. Sladen, as I said, he developed different animal models for endometriosis, and one of them, this is mouse model for endometriosis. So that's at the same time I prepared nanoparticles. Those nanoparticles, they were labeled with the fluorescence dye. And when we injected nanoparticles, so we saw that nanoparticles, they really preferentially accumulate in the endometriosis lesion. And you can see the signal in those lesions from the fluorescence. And the most importantly, when we did the histological analysis of those lesions, so what we can see here, so you can see in this figure panel E, the yellow color, it shows the blood vessels, and the red color, this is the fluorescence from our nanoparticles. So this analysis demonstrates that nanoparticles, they can be delivered with the bloodstream to the endometriosis lesion, and nanoparticles, they can escape from the blood vessels and accumulate there. So and this paper was first published in 2021. And basically, when we proved this concept, it gave us an idea that nanomedicine, which was widely explored for cancer treatment, potentially could be used for the endometriosis. And one of our first project, which was published in the current paper, so we want to see if the magnetic hyperthermia could be potentially used and developed for the non-invasive treatment of or non-invasive ablation of endometriosis lesion. So just a brief background, magnetic hyperthermia, this is experimental treatment, and it was tried in several clinical trials. And the idea of that treatment is that you have magnetic nanoparticles, and when those magnetic nanoparticles, they have special properties, and when you expose them to external alternating magnetic field, they generate heat. So the way how you can the way how these nanoparticles used in cancer treatment. So when you deliver nanoparticles to the cancer tumor, and after that, when you expose that part of the body to alternating magnetic field, you can actually remotely heat cancer tumor from inside. And when you reach a high temperature, obviously you can cause apoptosis or necrosis of the cancer cells. So one of the major limitations of current magnetic hyperthermia, that nanoparticles, which we have conventional nanoparticle, they have moderate heating efficiency. So you really need to inject very high dose, which could be toxic potentially, in order to have systemically delivered magnetic hyperthermia. And what happened in clinic these days? So the nanoparticles, they are injected directly into the cancer tumors. And after that, so right here you can see the device. It calls nanoactivator. So after the direct injection of nanoparticle into the cancer tumor, you can expose the patient to the magnetic field and just hit that cancer tumor from inside. So my team, we worked several years in order to develop nanoparticles which could have very high heating efficiency. And recently we developed a new approach. So basically right here, we developed new nanoparticles, we changed the shape, morphology, and so on. And when you compare these nanoparticles to the conventional nanoparticles, which are currently used in the clinical trials, like the spherical nanoparticles, our nanoparticle has like more than 6 times higher heating efficiency. So here on this graph, you can see the temperature profile of the nanoparticles in the solution. This is the conventional nanoparticle, this is our nanoparticles. So when we got these nanoparticles and we want to use them, like our idea was to test them in endometriosis. So we also, if you remember, I mentioned about active targeting that nanoparticles, if you modify them with certain ligands, they can accumulate in, for example, endometriosis cells. And what we done, Dr. Sladen, he just analyzed lesions collected for endometriosis lesions collected from monkeys. And we proved that endometriosis lesions, they overexpress VEGF receptor 2, or it's also known as a KDR. So the expression of KDR in lesions in endometriosis tissue is like several times higher than when compared to endometrium and some other organ, like here you can see kidney. So what was done in my lab after that? So we found a peptide which is targeted to the VEGF receptor, and we chemically attach this peptide to the polymer, and we cover our nanoparticles with the polymer. So those magnetic nanoparticles now they have peptides on their surface, and potentially, when they deliver to endometriosis lesions, they, for example, they can be uptaken by the stromal cells. So here's some in vitro study. We show this is non-targeted and peptide-targeted nanoparticles. You can see the, the internalization of those nanoparticles in the endometriosis cells is way higher than non-targeted nanoparticle. And the same we prove with the flow cytometer. So the next step was we use one of the mouse model developed by Dr. Sladen, and we injected nanoparticles. They were also labeled with the fluorescence, and right here those are lesions, and you can see there is a strong signal. So it shows that nanoparticles, they can passively, after intravenous injection, they can accumulate in those lesions. Another big importance of our nanoparticles, they also could be used as a T2-weighted MRI contrast agent. And right here, we also show the, we tested the distribution of those accumulation of those nanoparticles in the endometriosis lesion. And you can see here, when compared to the control mouse with the lesion, so the signal in mice treated with our nanoparticles dropped like by 50%. So it just gives the idea that those nanoparticles, when they deliver there, we can use MRI, just to confirm that they're in the lesion, and after that, the targeted magnetic field could be applied specifically to that part of the body. And here, this is section of the lesions, and this blue color here demonstrate the iron. So because our magnetic nanoparticles, they are iron oxide-based nanoparticles. So it shows that our nanoparticles, after systemic administrations, they get to the lesion, and they basically penetrate inside of the lesion and, more or less evenly spread there. So finally, what we did, we exposed those mice to the magnetic field, and technically for the first time, we demonstrated that it's possible after systemic administration of nanoparticles, it's possible to increase the temperature up to 50 degrees in the tumor. And at the same time, the magnetic field by itself, if you have a mouse without nanoparticles injection, so that magnetic field doesn't induce much heat. And finally, we also did some to evaluate the therapeutic efficacy in mice. And you can see here, for example, like we have lots of data, but since I don't have enough time, I just show you a mouse with 2 lesions, right? And what we did, we specifically, use targeted magnetic field. We applied the magnetic field only to 1 lesion. And after like 20 minutes of exposure, so we followed those lesions, you can see we were able to ablate this lesion, and at the same time the nanoparticles, they didn't have any effect on the other lesion. And the last slide, so this is what we published in that paper, and I just want to share with you our the most recent study, because like this paper has a limitation because the animal model, this is a mouse with engrafted monkey tissue. So during the last few months, we identified 2 monkeys with natural endometriosis. And what we done, we injected our nanoparticles. First of all, we wanted to see the safety of nanoparticles. So after the injection, so monkeys, they didn't, we didn't see any side effect. And the most important, we observed that our nanoparticles, they also accumulate in the natural lesions. And so it's kind of was very important step for us, because before we use mice, SCID mice, with basically, they don't have a full immune system. And here we just did the studies in monkey, and see that, so the nanoparticles, they don't clear from the systemic circulation, they accumulate in the lesions. And you can see here this blue color, it shows the distribution of iron. And we also show that we can, in monkeys, we can achieve the temperature like around 40-60 degrees. So this is what I wanted to share with you. I just want to thank my people who work on that and the funding agency who really supported that project. Thank you so much.
Oleg, thank you so much for this presentation. It's it's for us as endometriosis surgeons, is really interesting seeing a completely different side of what's possible. I've got a few questions for you, obviously. I see a lot of potential in what you've just presented us, and I see it in a couple of different ways. One of them would be the treatment sides of things that you've discussed, and I will have a few questions on that. But the other potential is diagnostic features. You've mentioned that you can pretty much highlight the endometriosis nodules or endometriosis deposits on an MRI scan. Did I understand it correctly?
That's correct. Yeah, those nanoparticles, they are MRI contrast agents. So, and they can decrease, they are T2-rated agents, and they can decrease the signal in the MRI, in the lesions.
And this potentially means that units without a specialist radiologist that deals with endometriosis can actually start picking up patients with endometriosis much easier. The diagnosis criteria is going to be much faster than before, because you're going to eliminate that human factor of looking at the nodule and trying to describe how big is the nodule, where exactly is it. It's really interesting. And of course, for the neuropalliology patients that we see, for the patients with sacral nerve roots, for the patients with pudendal entrapments from endometriosis, that's another exciting part of what you've just spoke about. But where do you, so that's amazing, but where do you see the sort of treatment dose or aspect of it? Do you think that this would be something that we could use potentially for patients with endometriosis, whether it's superficial or deep, or do you see it as a combination of perhaps surgery and excision and nanoparticle treatment to perhaps eradicate the macroscopic disease that we don't see during surgery? Or do you think that it would be something that we might use in theater, for example, like neurosurgeons do when they have a MRI in the operating field, to make sure that we excise all the disease?
All right. So yeah, when we talk about this specific project, I think this technology could be used for the treatment of like superficial and deep-seated lesions. And one of the reasons for that, because the magnetic field which we use, it can really penetrate deep into the tissue, and as I said, it was already tested for brain cancer and prostate cancer. So technically, if nanoparticles are there in the lesion, so it could treat, different, like different lesions. Like, doesn't matter if they are superficial or the deep-seated lesion. As I said, like, I'm not an expert in endometriosis, but like the way how we see that, so I hope, like if it goes well, so one of the applications would be that this would be potentially could replace the surgery. So it could be one of the non-invasive treatment, or or this treatment also could be complementary to the surgery. So, for example, if during the surgery some lesions were missed, so this treatment could be applied once and can eradicate, a very tiny lesion. Because in this paper we show that we can, this therapy can eradicate the lesions like 1 millimeter in diameter or so.
It's very exciting. We might be all out of jobs soon, I'm afraid. As surgeons, but it's really promising, and by all means we are doing it for the patients. So it's really good seeing the new ideas coming in. Do we have any questions from the audience?
Yeah, a few questions. There is a question from Jamie Nash, and would the patient feel any pain while the nanoparticles are heated up during the MRI?
I hope no, and I just will try to justify why I think like that. Because first of all, I said that this treatment was tried for already in clinical trials for cancer patient, and nothing was reported. So, and we also try this treatment in animals, and we also don't see any pain. So this treatment is very kind of targeted, right? So nanoparticles by themselves, they are not toxic, they don't cause any pain, anything like that. And magnetic field also, so doesn't do any harm to the body. And only, when you combine them together, so you can have the temperature, increase the temperature in the tissue. And obviously, like the temperature which we use, it doesn't have to be very high, like 100 degrees or so. So what we see here, if you increase the temperature like to above 46, between 46 and 50 degrees, I mean, it's high temperature, but it's not that high, just to cause some severe pains. And again, it's not that heat is not going to be generated in healthy tissue, only in the lesion.
And then there is another question from Aishwarya Payapili. I remember reading this actually in your paper when I read it, but how long the nanoparticle stays in the endometriotic lesion, and what is the time frame until when they're no longer detectable in the body?
Yeah, it's a very interesting question, and because like when we just compare I will answer the question, just give you some background a little bit. When we just draw the parallel between cancer and endometriosis, so in cancer tissues, so nanoparticles, they can stay, like for days. And one of the reasons for that cancer tissues, they have impaired lymphatic drainage. So what we notice here, that nanoparticles in endometriosis lesions, they also can stay for many days, at least, for 5-7 days. And in our specific paper right here, so we apply the magnetic field like 5 days after the administration of nanoparticles. And one of the reasons for that, so it's a good thing that nanoparticles stay a long time in the lesions, because during that period of time they can clear from the body, and technically, you can just avoid any potential collateral damage to other tissues. So what I can tell you, at least 5-7 days they can stay in the lesions. So and I don't know the reason why, because as I said, in cancer, the lymphatic drainage is impaired. But as what I learned from the literature, because I also wrote the review paper, this is the opposite case in the endometriosis lesion, but still nanoparticles, they retain there, and we have to do more studies why.
And in general, secreted from where? From the liver, from the kidneys, the nanoparticles?
See, like the whole idea of nanoparticles, because I just want to make it clear here. So nanoparticles, obviously, like they don't belong to our body. And when you inject them, so the immune system, try to clear them, and nanoparticles, in addition, they accumulate in the cancer tumor or endometriosis lesion. They also go to what we, at least in this specific case, we saw that they go to the spleen and the liver, and yeah, so two major organs. But yeah, but eventually, you know, they can be cleared like in relatively short period of time, but at the same time they stay in the lesion.
Understand. I have a personal question. I don't know if you can answer this one as well. How much would it cost, like a treatment with nanoparticles on average then?
I mean, yeah, that's a very interesting question. I can, you know, like what I can tell you, what would be the price, you know, just to make nanoparticles. So one injection of nanoparticles, you know, would cost, you know, at least, you know, just to produce them, it's about like $200, $300. And obviously you know, the instrument which generate the magnetic field, you know, it probably costs, you know, close to $1 million or so. So I don't know. So based on these, you know, numbers, I don't know how to derive the final price in the clinic. So and yeah, that's what I know at this point.
Brilliant. Carl,
I
do you
have one question. Sorry.
Sure.
You know, with like the clinical trials for the cancer patients, were there any recorded complications or main side effects from this nanoparticle treatment?
I mean, as far as I know, you know, what I learned from literature about this clinical trials. So, I mean, I didn't read about any serious adverse effect.
Thank you. Right, Mikey, back to you.
back to me? Kai, was there one more question about wavelengths?
Yes. So if you haven't mentioned already, can we just ask about the excitation wavelength and or range that these nanoparticles require?
All right, so yeah, that's a good question, and that question, as far as I understand, is related to our previous paper. So in the previous paper, we developed nanoparticles for the fluorescence imaging, and the idea of those nanoparticles was that you inject that systemically. Those nanoparticles, they go to the lesions, and they activate the fluorescence, and basically could be used for the fluorescence guided surgery. And we reported that paper in small, like, in 2020, and we also tested this technology for cancer, for image-guided surgery for cancer. And actually, you know, we patented this technology, and one of the startup company just, you know, got our license. So the wavelengths which we use, it was around 800 nanometers, and the reason for that, because this is near infrared range. So our body tissue and fluids, they also absorb, and they have autofluorescence in the visible part of the spectrum. And near infrared range, there is something what we call biological optical window, when the absorption and autofluorescence is kind of lower. So yeah, it was around 800 nanometers. 780, you know, just to be precise.
And I'm right in saying your compound that you use, is that an iron-based compound? Is that correct?
In this specific paper, in magnetic hyperthermia paper, this was iron oxide nanoparticles, and they have 1% of cobalt in those nanoparticles. And cobalt, actually, this is element which help us to, you know, just to increase the heating efficiency in the presence of magnetic field.
Okay, thank you.
And those nanoparticles also, they were covered with the polymer, this polymer called polyethylene glycol, polycaprolactam. So that polymer was tested like many times in clinical trials and widely used for the drug delivery.
Oleg, and last question from me. Do you think that in the near future, we're going to be able to have the technology to inject the nanoparticles and then have the camera setup that will allows us to see where exactly endometriosis is with fluorescence or with light?
Yeah, you just try to, you know, give like a fair answer. I think so, because right now, you know, the nanoparticles, when we're talking about the fluorescence nanoparticles, they mostly could be used during the surgery, because, you know, as I said, there is a strong autofluorescence, and you cannot just scan like a human body and see the fluorescence even in near infrared range, because you will have lots of interference. But during the surgery, yeah, I mean, there is a special instruments this day, you know, clinical approvals like Fluorobeam 800, so they could be used during the surgery. So this technology is already in clinical trials, and like some other nanoparticles focus on that. Other techniques, for example, like MRI imaging and nanoparticles, magnetic nanoparticles, they are widely tested for MRI imaging, and they also could be used for some other contrast agents, which can overcome the fluorescence challenges, such as photoacoustic imaging, for example, ultrasound, and so on. So I just want to give you the perspective about nanomedicine, just a few words only. Nanomedicine been around for a while, and like some products, they reach the clinic, for example, like these magnetic nanoparticles, like Doxil. This is Doxil. This is lipid nanoparticles with the doxorubicin, right? It's also already in clinic. There are some other examples, but I think the major breakthrough was this unfortunate event as the pandemic. But at the same time, it was really a good example how nanomedicine could be used, because I'm sure you know that Pfizer and Moderna vaccine, this is nanotechnology. Those are lipid nanoparticles loaded with messenger RNA. And yeah, I hope right now it's going to be the growth of nanotechnology, especially in the clinic. Because for a long period of time, it requires a lot of studies and everything else. Because again, nanoparticles, it was a concern, how to test their toxicity, the long-term side effects, and so on. Yeah, so that's what I know about.
Well, I think you're doing a brilliant job. So honestly, thank you very much for sharing it with us. I found this personally, I know Ben as well and the whole team, we find it really, really cool and exciting. And it's certainly really a good big step forward, especially for the patients. And that's why we do what we do. Right, well, I think on that note, I think we're gonna close the webinar. Thank you very much, everyone. Thank you, Oleg. Thank you, Martin. Thank you, team. And
thank you everyone for having me here.
Have a good evening, and thank you again.
Thank you, Oleg.
Bye,
everyone.
Yeah, and if you have any questions, in the future, just please feel free to send me an email. I'll be more than happy just to work with you, or just to discuss something. Thank you so much.
I think we will. We certainly will. Take care. Bye-bye.